Okay, welcome back to part 4 of mixed cases in endocrine and antimicrobial drugs. Wow. We're looking at these flashcards which I downloaded from Amazon.com onto my Kindle, and now we're looking at these to study for my quiz. So we're going to scroll down past the cases we've already done, and we've moved on to the antibacterials. So we're not going to cover everything, but we will cover some of the main points when looking at these cases. So let's first talk about the beta-lactams, and the examples of these are the penicillins, ampicillin, methicillin, piperacillin, aztreonam, imipenem, and the cephalosporins. So thinking about how these work, protein synthesis inhibitors, which ones are these? So the 50S ribosome, so that's chloramphenicol. The macrolides, for example, erythromycin and clindamycin. How can you remember these? No idea. How about the 30S ribosome, aminoglycosides such as gentamicin and the tetracyclines? So the antimicrobacterial agents such as rifampin, isoniazid, and dapsone, and ethambutol, and pyrazimide, I can't pronounce it. These are shown here. I might talk about these and other antibacterial agents such as trimethoprim and sulfamethoxazole and fluoroquinolones such as ciprofloxacin and vancomycin and metronidazole. Okay, we're going to try and present some classic cases here. So let's start with the first one. A 22-year-old male presents to your clinic complaining of a new lesion on his penis for 1 week. On physical examination, you find a single painless ulceration with a firm border. Upon further questioning, you discover that he has been having unprotected sexual contact with several individuals over the last several months. Physical examination is also remarkable for enlarged lymph nodes in the groin, axilla, and supraclavicular regions. Suspecting a specific sexually transmitted disease, you send him to the lab for a RPR and VDRL test. When he returns from the lab, you empirically treat him with a shot of antibiotics, and you warn him that the rare side effects of his medication may include a hemolytic anemia. So this is penicillin. So similar to this is penicillin G, penicillin 5, and the MOA here is that it binds to PBPs, thereby blocking the peptidoglycan cross-linking, the NAG and NAM cross-links. And the uses for gram-positive cocci and some gram-negative cocci. And the side effects, allergic reaction, you might get a drug-induced Coombs-positive hemolytic anemia. So let's try to remember that. Okay, next one. Ampicillin. What's the difference between ampicillin and penicillin? Well, now we're talking about gram-negative rods. So let's talk about this case. A 54-year-old male presents to your clinic complaining of a 3-week history of severe sinus congestion. He describes his sinus congestion as a green and purulent, and he also reports fevers of 104 degrees Fahrenheit. He has been trying symptomatic therapy with nasal decongestants for the past 2 weeks with no improvement in his symptoms. You decide to prescribe him an antibiotic to cover the likely pathogens, pneumococcus, Haemophilus influenzae, or Moraxella, that may be causing his symptoms. So you would give him ampicillin. Why? Because pneumococcus, Haemophilus influenza, for example, these are these key gram-negative bugs that will say you need ampicillin. So similar to this is amoxicillin, ampicillin for these things. Pneumococcus influenza, for example. It binds the PBPs, thereby blocking peptidoglycan cross-linking. Gram-negative rods. Side effect, non-allergic skin rash. Other, amoxicillin can be given in oral form. clavulanic acid, and sulbactam. We'll talk about those a little bit later. Okay, next case. A 54-year-old drug abuser is admitted to the hospital and suspected osteomyelitis in his lumbar spine. Blood cultures are taken in the ER and broad-spectrum antibiotics are started. After 2 days, his blood culture shows growth of pan-sensitive Staph aureus. This is the key word here, Staph aureus. Staph aureus methicillin. In order to prevent overuse of stronger antibiotics that should be reserved for multi-drug resistant cases, you discontinue the current broad regimen of medications, and you begin the patient on a more specific antibiotic. So this is methicillin. So if you can remember Staph aureus and methicillin, you'll be looking good. Similar, nafcillin, oxacillin, and dicloxacillin. This bind PBPs again, thereby blocking peptidoglycan cross-linking. So uses Staph aureus. There were others, but I focused on this. Side effects: interstitial nephritis, other methicillin and beta-lactamase resistant bugs. So, can we remember this? Methicillin, Staph aureus. Okay, let's do one more. A 42-year-old burn victim is admitted to the hospital for possible infection at his burn site. He has suffered a third-degree burn 2 months earlier and has just been released from the hospital after a failed skin graft procedure. The patient has a fever of 102, blood pressure of 90/50, and a wound that is oozing purulent discharge. You send a sample of the discharge for culture and you begin broad-spectrum antibiotics. The culture grows out pan-sensitive Pseudomonas. That's the key word here. So Pseudomonas, you decide to change the patient's antibiotic regimen to a medication that is commonly used to treat his aggressive organism. So when you see Pseudomonas, you know that it's piperacillin. So these are the similar drugs. I'm moving ahead a little faster, but another similar drug may be Klebsiella. Okay, let's do one more. A 45-year-old white female presents at the ER with increased urinary urgency and dysuria. She reports that this has occurred several times over the last year despite antibiotic treatment. Upon review of her medical records, you notice that she has been treated with both first and second line pharmacologic agents for her recurrent UTI infections, which have been caused by long drug-resistant strains of Klebsiella and Serratia in the past. Her medical history is also notable for an allergy to penicillins and cephalosporins. These are your keywords right there. On physical examination, she is febrile at 101 and has a blood pressure of 90/50. You draw urine and blood cultures and you decide to put the patient on a broad-spectrum beta-lactam drug. Another one, broad-spectrum beta-lactam drug. That is effective against gram-negative rod infections and can be used in penicillin allergic patients. Aztreonam. So if you're allergic to penicillins, Aztreonam. Monocyte B-lactam ring blocking peptidoglycan cross-linking. Gram-negative rods. Oh, Pseudomonas is here. Ooh. Where was Pseudomonas before? Let's look up there again. That was for piperacillin. Oh, now it's getting confusing. Where am I lost? Okay, we're here. So side effects, not a cross-allergen of penicillin. Other Aztreonam is a relative resistance to the actions of beta-lactamases, patients allergic to penicillin, or in patients who are renally insufficient. So there you go. Let's take a break and we'll come back with another case. Thank you very much.